Hey, here's another series. We'll probably cut it into 3 or 4 different cuts over a week when you're seeing this. So the topic that we're going to get after is I'm thinking of one major one that's very recent, meaning over the last week, but some of the other decision making process, particularly before you get the ACL surgery. Okay, right now, a lot of the suggestions we'll make is based off a real individual, so they have very particular uh, characteristics that will be addressed. Not everybody will have every single one. More importantly, the thought process is going to be very similar for everyone. Let's check all these different boxes and let's see who needs what. Now, the first thing that we're going to get into is number one is choosing your surgeon. Okay, and with that, what is the type of procedure? Now, it's very reasonable that competent physical therapists are going to have an opinion on the type of procedure that they're seeing success with the surgeon that they work with. I do not. I have zero opinion on the type of surgery. I am intentionally, completely ignorant on the different types of choices that are available for an ACL repair or reconstruction for a couple reasons. Number one, I'm not the surgeon, so I don't have experience in forming an opinion on what we're doing. And as a therapist, if I don't see every single patient that surgeon performed a procedure on, all of the ones where they did X and all of the ones that they did Y, I do not have, in my opinion, utility to comment on, yes, we should be doing patellar tendon versus hamstring versus gracilis versus cadaver, whatever. Certainly, I do think there's a regional approach, meaning different parts of the country seem to have preferences. What is more important to me, and that's why we start with this, is to have the type of communication and the type of respect that you want, that makes you feel the most comfortable from your surgeon, whatever that might be. I think at the levels of healthcare engagement that I think is quite possible. Like at times when you're working with the best surgeons in the world, if they can show elite levels of respect, elite levels of communication, and elite levels of a customer experience, because just because you're a patient doesn't mean you're not a customer. When you have those things in place, choose that. And basically, if you were in a service industry, you should be treated as if how you would treat a relative or your grandmother. I think very often we get used by the healthcare system, and because it's such a special and exclusive product that we're buying and consuming, we don't know what is good or not good. Well, if you attach to someone who does and you appreciate their forms of communication, the communication from the surgeon should really be the same. To that end, do what the surgeon says. They have their choice. I don't think they're making their choice for you because they think it's bad. It's because they think it's the absolute best way and there's no other way. If they're going to tell you. If they tell you, well, I'm not sure, we might do this, I don't know that. Maybe, number one, maybe it doesn't matter because they're 50-50 on the unique characteristics of that patient. But, that part is not imminently functional. You just pick and you run with it. It's very difficult to suggest I have a hard time suggesting one surgeon is better than another because again I'm not a surgeon and I don't see all their patients. What I'm very, very comfortable suggesting to my patients and my clients is how will this individual communicate and will they be part of a team that works for the patient. At no point will I recommend a surgeon who doesn't respond to phone calls. I get it, there's privacy issues in terms of using a portal versus the email. I'm rolling my eyes. Okay, really? But anyway, if that individual had a serious confidentiality issue, I get it. Then they want to stick with the portal. Okay, but ultimately the communication should still be very, very open. There is no waiting 3 hours in the waiting room. There's no waiting 3 weeks, which we'll get to in the expedience of how these procedures should get done. But no, I don't, and maybe most importantly, they are not going to be heavy-handed in anything training or rehab related beyond their protocol. And remember, protocols are in ranges. Those ranges are there for a reason, and they should be followed without reproach. What maybe can be on the other end of that is training the rest of the body as aggressively as possible, and the better you go into that approach, which we'll get to probably in one of our later points here. So number one, pick the surgeon that makes you feel respected as a customer and a patient. I think that's very, very important. Number two is the time it takes. Now, this can go a lot of different ways. Now, if the first opportunity that you have to get imaged, which again, a lot of people are dealing with insurance issues, etc., bottom line is a patient that I consulted on several months ago had a very significant posterior lateral corner component to their injury. With that in mind, to take weeks to engage in a surgical procedure, not a great idea, because that posterior lateral corner will scar over at some point if we don't intervene, and then can have significant neural compression in that area. So if you're not even getting imaged, or you're not even sure if you have an ACL, and there's a big time posterior lateral corner issue, that's something that's a big deal. But in other situations, I have no issue if there is no hard time frame to get back to. Obviously everybody wants to get back as quickly as possible, but if there's no hard date, where there's no difference between coming back in October versus December, I say take as long as you want to train before the procedure. And a lot of really, really good things can happen there. Something else that needs to be certainly accounted for in that pre-training process, a lot of times after an ACL or any kind of knee injury, is a lack of knee extension. To go into a surgical procedure, unless there's some other more pressing orthopedic / medical concern, going into a knee procedure without full extension is kind of, you're looking at an all kind of hell situation. So if we can get into a training process, which is be our third approach, there's a lot of good things that can happen. Number one, we can clean up any of the extension or range of motion issues. Number two, we can start to learn a lot of the initial phases of training. A lot of times the best experiences that I can go back to is the 13, 14, 15, 16-year-old females in high school. There was a period of time where I was actually working in the real world and seeing these people for significant periods of time because of the setup that we had. And we're finding that these are the most special experiences for me, because these young girls were getting into the weight room for the first time, and they never would have gotten in the weight room. Other people that are in the weight room, but you take the time to train before the procedure, get back into some things, and then you come out much faster. Okay, you're never going to trump the protocol, but you're able to impart more stress, more load, more complexity within the parameters, so then when you reach the next checkpoint, you have an even higher load, and this exponent of load is how you can probably get out of certain phases after 3, 4, 5 months much quicker than someone else. So when we talk about the considerations before the procedure, if you can even train 2 months, and there's nothing going on, now you are dumping a very positive humoral and hormonal effect, so that you've got the range of motion, you've got an increased training age, and now you have a work capacity environment that is more loaded up, so that you can get out of just even if it's just anesthesia, to have a more robust immune profile, gets you out of that quicker, and you start the training rehab process, whatever you want to call it, much quicker. You start quicker, you get more work done. Next checkpoint, you're starting at a higher level. So I think this is where you start to see these gaps and these differences. But then when you see the research that talks about, well, maybe it's 2 years until the ACL patient or client is at no increased risk. I'm not saying that's false in terms of the research. I'm going to thumb my nose right there, because I'm not convinced that those patient populations have been training and doing everything that's part of the training process at an elite level, okay? And then the last piece that we can get at in this phase is really uploading the nutrition piece. Because not only will the nutrition support the goals of the training process in this pre-training phase, it does give us an opportunity to begin to safely and sequentially add calories, hopefully carbs, that will support the acute rehabilitation process. We've talked a little bit about this before, and we have another IG Live that we'll put together that talks specifically about this piece with a very real situation that I was sort of involved in, where basically 3 career-ending, season-ending level injuries within a year and a half, and some of the components that led to that. Here's the deal. When we know that that quad is significantly atrophied, how is it going to get bigger? Well, it's going to get bigger with protein. And if you're using protein to drive the engine, well then because you're not eating enough carbs, well then protein doesn't go into the muscle to make it bigger and or stronger. So we can have increases in strength without hypertrophy. But if we are after hypertrophy, which we are in the early stages of rehab, we need the carbs to drive the engine, which is idling at an increased RPM to begin with. So what is the preferred source of energy? It's carbohydrates. And if we probably need to eat significantly more carbohydrates post-surgically. Let's use this 1 month, this 2 month, 6 weeks period to sequentially increase calories. And I think we would typically also find, just by engaging in that process, that most people in general are either below even just normal amount of calories to be a slug, normal BMR, we're not even hitting those calories, much less having an ideal distribution of protein, carbs, and fat. I don't know what that ideal distribution is for everybody, but I do know what a non-ideal is. If we're nowhere close to calories and we're nowhere, or we have these notions that some of these general population fat loss programs have anything to do with athletic training, athletic development, or any type of post-rehab process, okay? So where we go, we pick the surgeon, we respect the time. Is there expedience, is there not? Is there something that you have to come back to? Let's get into training as aggressively as possible. Let's clean up some things that might be a significant deterrent, or things that you can just start to get going that would be outside of the rehabilitation of the knee in a myopic fashion. And then let's start to dial in nutrition. And of course, whenever we talk about nutrition, we also need to talk about sleep. So whatever that may be, let's start to dial that in as well. So this is really not a scary time, because if you can nail all of these things in this figurative month before the procedure, you're going to get 2-3 months back at the end. And even if they don't get those months back to return to play for some other logistical reason, you have another 2 to 3 months of putting increased complexity, increased load, increased demands, so that when that bell is rung, we're in a much, much better place. I understand that to me, that really shouldn't be like this blue sky, unimaginable environment. I get it. In general population, it usually is. So basically, over the next couple videos, we're going to fill in some gaps that we didn't talk about in ACL in action, which was really about the rehab process, not necessarily the rehab. We're going to talk about some things that we would like to see in the foot. We're going to talk about some things that maybe we would see at the hip, that we would get after in week 1 or week 2, but we would start in this pre-surgical phase. So let's maintain some ideas. Let's see if we can get some engagement here on questions, so that when I see them, we can add them into the subsequent videos. Okay, so we'll make a video of some manual therapies that I think would be very useful early on. We'll show some videos on how we could take some special exercises to those, and then we'll come back to the whiteboard and let's look at what this program ideally would look like for that young female that probably hasn't trained much in the first place. So beyond that, if you have seen a leprechaun, say, yeah,